So in this section, which is a continuation of rheumatological conditions, I'm going to discuss rheumatoid arthritis. But before I actually discuss rheumatoid arthritis, I'm going to focus on the pain pathway, and also just the management of pain, because I feel as though I never really talked about the management of pain at all. I only mentioned chronic pain, and also when I mentioned chronic pain in the last recording, I actually forgot to, well, I made a mistake in saying that pain will transmit and propagate towards the epilateral side, when really I drew the contralateral side. So really I should have said that talked about the crossing over of the spinothalamic tracts from the dorsal horn, crossing over to the contralateral side, but I said it's lateral side. So I just want to quickly review that. So in terms of pain generation will start at the peripheral nerve. This is pain. Peripheral nerve, which is usually called the primary nerve, because remember, pain is impulse, transmission. So you will get chemicals that will, and the first order of nerves, they can be A fibers, which are A alpha, beta, or delta, or they can be C fibers. C fibers and the A delta fibers are slow conductors, slow conducting fibers, fibers, and C fibers are unmyelinated. I think I covered this in the last section, so I'm not going to cover this in this section. And these ones are myelinated. D is, however, small, which is why T is a slow conductor, and they are all really chemoreceptors, which is why they will respond to chemicals. So they are, we define them as chemoreceptors that are activated or stimulated really by cytokines such as bradykinin and the prostaglandins. Obviously the prostaglandins being generated via the COX pathway, which is why inhibiting COX enzymes by using analgesics such as ibuprofen, which are non-steroidal anti-inflammatories, or indeed paracetamol, works for to relieve pain due to inhibiting the cytokines and the chemicals that stimulate or prime the nerve cell to then fire an impulse. There's also histamine and serotonin, of course. And potassium ions will again also cause the primary neuron to fire. So once the primary neuron really is in the peripheral nerve, and it propagates its impulse directly into the dorsal horn of the spinal cord. So I'll quickly draw my spinal cord once again, albeit that I did cover this previously. I mean, it doesn't harm anyone to repeat this. So again, this is the dorsal horn where this primary neuron will fire directly and synapse with the secondary neuron. So the secondary neuron is in the dorsal horn of the spinal cord. So this is the spinal cord. And usually the secondary neuron is usually myelinated, which means that obviously it can then propagate impulse faster than even the slower conductors from the C fibers or indeed the alpha delta fibers. Once that stimulus is received, this neuron here is called an interneuron, and immediately as it synapses, obviously, you know, neurotransmitters are secreted there, causing, you know, that propagation of impulse. The minute it gets activated, it crosses over into the contralateral side, which is exactly what I said previously, and which I mean is exactly what I drew previously, albeit that I said ipsilateral side, which is obviously wrong. So it crosses over into the contralateral side, and travels in the spinothalamic tracts to reach the thalamus, where the third order neurons are based. And the neurons in the thalamus, really, that impulse is also, will then, so that synapse occurs there, and it immediately transmits into the cerebral cortex, like in the parietal lobe, cortex of the parietal lobe, and it also transmits into the limbic system, which I didn't mention previously. So it obviously the cerebral cortex will then perceive pain, and the limbic system really is for generating emotions, that emotional response to pain. So which obviously leads us to having pain as, you know, a noxious stimulus, an noxious, terribly unpleasant stimulus that also has an emotional and psychological with an emotional and psychological response. And really, that is what pain is, and it obviously has that emotional and psychological response due to the activation of the limbic system as well. So this is all really that I wanted to cover in terms of the propagation of the painful stimulus from the peripheral nerve, which is the primary neuron, into the spinal cord, which is the secondary neuron, and into the third neuron, which is found in the thalamus and is also a myelinated neuron. And indeed, I want to stress that that secondary neuron immediately crosses over to the contralateral side to then transmit that painful stimulus into the brain. And then the treatment of pain is usually based, not that is usually, is really based on the WHO, the World Health Organization step ladder for analgesia. Where step 1 involves using a non-opioid. This will include NSAIDs, including paracetamol, other NSAIDs really ibuprofen, and indeed the whole step ladder, whatever step one is at, there is always the inclusion of adjuvant therapies. And these include, I'll just write them here. So the adjuvant therapies for pain will include antidepressants, because if we can remember, serotonin as well does stimulate the peripheral nerve to fire that impulse, to undergo depolarization and fire. So we can give antidepressants, also antihistamines as well, and anticonvulsants, all during any stage of the step ladder, of the analgesia step ladder. Step 2 includes using a weak opioid, and this will include cocodamol, codeine, or indeed as a mixture with paracetamol, where it's cocodamol. And if pain is not obviously, like, to really move from step 1 to 2, it means that pain is not really being resolved or reduced by a non-opioid, and then that means that one has to move on to step 2. And if step 2 does not resolve pain, then a strong opiate is used, and obviously this will include morphine and fentanyl. Usually, in terms of strong opioids, we're obviously talking about people perhaps who have cancer pain, pain that comes with cancers. This is really strong medications, and all they do is, if we were to look at all the medications that are used in the step ladder, the opioids will inhibit COX, and all the opioids with the adjuvants will inhibit all the chemicals that actually stimulate the peripheral nerves. So then that is one first way of managing that pain. Whereas the opiate, what did I say? The non-opioids, the NSAIDs, the non-opioids will inhibit all the chemicals that stimulate the peripheral nerves, and then the opioids, whether strong or weak, will inhibit that sensation or the perception of pain. They work centrally in the central nervous system. They work centrally at the pain centers to actually modulate how one perceives pain and reduce the perception of pain. Neuroinhibitors, which are not part of the WHO step ladder, can be administered as well. And so nerve blocks, really, we call them. And all they do is that they block the propagation of impulse. So there are 3 ways of blocking the sensation of pain by blocking its transmission. The first one being at the peripheral, where one blocks or inhibits all the chemicals that stimulate the peripheral nerves, or indeed at the spinal, at the dorsal horn, where one blocks that propagation of impulse into the spinal cord, or indeed centrally, where the perception of pain is modulated and regulated so that it's not perceived as a noxious stimulus, or indeed the perception is reduced severely for one to then be able to get on with their lives, really. So that's all I wanted to cover in terms of pain. I'm now ever so quickly going to move on to, I'm just checking the time on my phone, to move on to rheumatoid arthritis. I was also going to do ankylosing spondylitis, but I think because I've started with pain, I'll just cover RA today, and then I'll then start hematology in these coming few days, while I still have time to complete all the modules, really. So in terms of rheumatoid arthritis is defined as, so this is defined as a chronic inflammatory disease, of synovial joints that presents with pain, stiffness, and joint tenderness, of the small joints, in particular of the hand. So in terms of looking at it really as a chronic inflammatory disease, it tells us that there has to be an inflammatory process, underlying inflammatory process going on there, and usually it commonly affects synovial joints. However, it can have extra articular features, such as having pulmonary nodules, which I discussed when I was discussing interstitial lung disorders, where I talked about having rheumatoid nodules in the lungs, leading to a restrictive lung pattern, restrictive breathing pattern. So although it mainly affects synovial joints, it can have those extra articular features, and it presents with pain, with a painful stiff joint that's tender and swollen as well, due to that edema and indeed inflammation, that's the underlying inflammation. The risk factors of rheumatology are females usually are at a higher risk of developing RA. I'll just say RA there. So they are at a higher risk, and usually premenopausal women are 3 times more likely to develop this RA when compared to their male counterparts. However, after menopause, the risk factors is equal between between females and males, so there is no difference really. Other risk factors for RA include the genetics, specifically the leukocyte, did I just say leukocyte? In fact, it's called the human leukocyte antigen, which abbreviated as HLA-DR4, which really confers autoimmunity that's driven by CD4 positive T helper cells, but we'll get to that anyway. Other risk factors include a family history of rheumatoid arthritis, smoking, obesity. Obviously, obesity will increase, pressure on the joints, really, and smoking has a lot to stimulate cytokines and stimulates inflammation, really. Other risk factors will include a previous abortion, or previous recipient of blood, so blood transfusion. And reduced tolerance. Obviously, again, leading to the propensity to develop autoimmunity. With RA, there are three phases of the disease, and the first phase begins with a really non-defined underlying inflammatory pathology of of no basis, really, where just wrap this out, where an inflammation occurs that then triggers reduced tolerance and triggers autoimmunity. So if we were to say there are three phases, so there is non-specific. Phase 1 will be a non-specific inflammatory. Specific. This can be, something like post-viral inflammation. It can just be through HLA-DR4 triggering inflammation. It can just be due to reduced tolerance of, undefined origin. So it can be post-viral, or shall we say just post-infection, where that inflammation just never resolves. Or it can be due to genetics. Again, genetics being primed by environmental factors such as smoking, or being primed by glycosylation of antibodies in the human body. So people with DM, where proteins become glycolated, and therefore trigger an inflammatory response, and really just reduced tolerance to one's own cells, really. So it's a non-specific trigger of inflammation, and what that non-specific trigger of inflammation does is that it then activates the residential macrophages, which then propagate the inflammatory process that we see in chronic inflammation. So the second phase really will be the activation of macrophages, and indeed dendritic cells, which are really part of macrophages. And the activation of macrophages can be due to whatever that underlying inflammatory process of non-descriptive basis, really, which is non-specific as well. What it does is it primes B cells to differentiate into plasma cells. And the plasma cells will then secrete rheumatoid factors. I'll just write it as, I know I've used RF for risk factors, but these are rheumatoid factor, and indeed the anti-cyclic citrunylated peptidoproteins, both of which are antibodies against one's own cell. Rheumatoid factor specifically, I'll talk about that, is, so shall I call this the green RF? Well, the RF with a dot in between. So rheumatoid factor is an antibody. Remember, plasma cells secrete antibodies, so really that's all I need to say about that. So rheumatoid factor is an antibody against the Fc region of IgG, IgM, and IgA. And it obviously then attacks all of those Fc regions. And if you remember, the Fc regions are the constant regions of the immunoglobulins. And rheumatoid factor also, all the rheumatoid factors can also then form complement complexes and again stimulate inflammation. Because if we're to remember, complement in its true form, it's a mechanism for the opsonization of bacteria. Therefore, if complement is formed on any tissue, on any cell, it just causes macrophages and dendritic cells to engulf and opsonize that. And once they opsonize or engulf, so these are macrophages which take up whatever it is, whatever is primed them, an antigen, shall we say, and then they'll just present it on their MHC2, because of course they are antigen presenting cells, so they will present that, and that presentation really then activates the T helper 2 cells. I mean, this is normally what will happen. Say if this was a bacteria that needed opsonization, this is exactly what will happen. So that formation of complement then causes exactly the same process to happen. But obviously there is no pathogen there. That is a self-antigen that is being presented to the self. Anti-CCP antibodies work similarly in the sense that, so the anti-CCP are specifically targeted at the citrullinated regions of the peptides. And really, citrullynation is a post-translational mechanism that's specific to amino acid arginine. And once these self antibodies present the self antigens to macrophages, inflammation begins, and macrophages do what macrophages always do. All they know to do is to secrete cytokines and lysosomes, of course. Cytokines including IL-6, IL-1, and TNF-alpha, which propagate inflammation. Because if we can remember as well, these are acute phase cytokines. Which recruit further cells. So they recruit lymphocytes. And then what I must also mention is that rheumatoid factor and anti-CCP, obviously, you know, oh yeah, yes, I have said it, they are self-antigens. The activation of these inflammatory cytokines will recruit lymphocytes, specifically the CD4 positive lymphocytes, and another aspect of phase 2, so this is phase 2, another aspect of phase 2 is the secretion of rank and its ligand, really, which are for bone remodeling. So really by phase 2, the body systems are all primed and ready to begin the destruction process. And I say this because there is already enough lymphocytes there that have been activated. There are cytokines that will obviously propagate this inflammatory process. In terms of TNF will, you know, constantly activate macrophages, as in TNF, and obviously the rheumatoid factors, and indeed the anti-CCP will continuously activate macrophages, and macrophages will continuously recruit lymphocytes. We also have the rank ligand as well, waiting there to undertake the final phase of rheumatoid arthritis, which I'm moving on to now. So phase 3 of rheumatoid arthritis really is a chronic inflammation phase, and in that chronic inflammation phase is where all the destruction actually happens. So now that we have all the cells and cytokines ready in that synovial joint, we enter phase 3, which is the chronic inflammation phase. And in phase 3, we will have, if we can remember, a synovial joint is a joint which has a proximal bone, so this is the proximal bone, and a distal bone, both of which have cartilage on the articular surface, obviously to reduce friction and allow and absorb shock as well. They will have a synovial membrane, which should be drawn in a different color since it's the site of pathology. So they will have a synovial membrane there.